Hello, everyone. This is John Pauli from Gothenburg, Sweden, and I'm happy to be back at the Guinea World Skin Health Day Congress of 2025. This year, I'm going to be talking about the dermoscopic findings that will help us identify high-risk facial basal cell carcinoma. So the first question we might ask ourselves is, which incomplete excision rate do we find acceptable for basal cell carcinoma? Especially for the high-risk cases located in the facial region. Well, of course, we can't debate this together, but if we did, I think we would probably agree on approximately 5%, so 1 out of 20. This is perhaps our goal. It's hard, of course, to get 100% complete excision rates, but we don't have too many incomplete excisions. So let's keep that in mind when we look at the data on what we actually achieve with normal surgery compared to other techniques like Mohs micrographic surgery or other micrographic techniques. So 5%. We looked at the clinical pathological factors associated with incomplete excisions of high-risk basal cell carcinomas at our department recently and published this in 2021. And we looked at 987 consecutive excisions with normal surgery, traditional surgery, of high-risk basal cell carcinoma. And it turns out that the incomplete excision rate was actually around 20.6%, so quite high compared to the 5% that we perhaps would find acceptable. Especially lesions on areas like the nose, ear, scalp, or the periorbital region were very difficult to excise completely. And in some cases of deeper infiltrative BCCs, which are the blue columns here, on the nose, for example, incomplete excision rates of 55%. And this was a rather large number of the cases. So really a problematic tumor. So, of course, the solutions to this is to use more micrographic surgery, more Mohs surgery, but of course this isn't very available in many parts of the world. So then for the rest of the world that doesn't have access to Mohs surgery, well, then you only really have wider excision margins to go with. But of course, how do we identify, how do we recognize these high-risk facial BCCs before doing the surgeries in order to apply larger margin? Because we don't want to apply super large margins on all BCCs, only on the ones that really need it. So this is what we're going to be discussing now, and this is the results. These are the results of a recent study that we published in Dermatology, Practical and Conceptual, which is the official journal of the International Dermoscopy Society. And we looked at the importance of not just dermoscopic findings, but also clinical findings, which we might think less about, in recognizing and predicting that a facial BCC will be of a high-risk histopathological subtype. And of course, which ones we're talking about here are the infiltrative types, the morphaic types, but also micronodular and other more aggressive subtypes. Okay, so a few years ago I spoke about subtyping BCCs, but more in general. So perhaps you remember and you recognize that in a case like this, we see very typical dermoscopic findings. I think the first thing that really catches our eye are the blood vessels, right? The so-called focused branched vessels, very typical for basal cell carcinoma, of course. In this lesion, we also find blue pigment, and we also find shiny white blotches and strands. So several dermoscopic findings that tell us that this is a basal cell carcinoma. This is straightforward. Let's look at one more case here. This case here, it's a little bit different. We don't see the vessels as clearly, right? But we do find some vessels after a few seconds of looking and searching. We'll see some vessels, but these are less focused, so they're more unfocused, and they're shorter and they're thinner. And we describe these as short, fine telangiectasias, unfocused, pinkish, and kind of dull, more difficult to find. In terms of ulceration, we see more erosion, so very superficial, multiple small superficial erosions. And in this case, we also see shiny white blotches and strands. Okay, so findings compatible with, again, basal cell carcinoma, even though it looks completely different compared to the first lesion. And now we have this case here, which kind of is in between in terms of the findings. But again, we do see the vessels, right? We see these focused branched vessels. We also see one single larger area with ulceration. So not really the multiple superficial erosions, but one area with ulceration. And then we also see shiny white blotches and strands, just as we saw before in the previous cases. All right, so again, findings which tell us that this is a basal cell carcinoma dermoscopically. But again, I mentioned that the clinical findings are sometimes forgotten. So the dermoscopy will give us the diagnosis. Now we know that it's a basal cell carcinoma. What can we now say about the clinical findings that may help us subtype the lesion, especially in the facial area? Well, we can look at what we've come to call the surface topography and also the clinical demarcation of the lesion. And of course, with topography, we mean, is the lesion raised? Is it flat, or is it kind of in between? So let's look at the elevation and the demarcation, right? So we look at the first case, and this is, of course, a clearly raised lesion, right? And it's very well demarcated, so it has well-defined borders. We really clearly see where it begins and ends, so to speak, right? So a raised with well-defined borders. And this is typical of the nodular subtype of basal cell carcinoma. We can recognize this. Then we have the second lesion in the middle, which is, of course, flat. So it's a flat lesion, and the demarcation is not as well defined. We might describe it as more ill-defined in this case. And this is, of course, typical for the superficial subtype. And finally, we have this lesion to the right, in which it might be more difficult to define whether or not it's raised or flat, or perhaps even depressed. And it might be a little bit of everything in one single lesion. And we don't have a name for this. We haven't until now. And in this article, we suggest that we call this surface topography bumpy. So a bumpy surface, okay? And a bumpy surface, not only that, but also ill-defined borders. So this is typical of the infiltrative subtype or the high-risk subtype. Okay, so this is the table from the article, just looking at the odds ratios for different features, clinical and dermoscopic features, which are correlating with the superficial, nodular, and high-risk subtypes. We're going to go through them one by one, so don't pay too much attention to the table at the moment. Okay, we can look at this lesion, for example, and we see a raised lesion, right, with well-demarcated borders, right? So clinically raised, and we have, of course, the branched vessels telling us that it's a basal cell carcinoma, and even shiny white blotches and strands. So if this is a basal cell carcinoma, it should be nodular, right? And we're looking at just that part of the table. You can see that only raised has a very high odds ratio of 6.1, well-defined borders 5.4. And then, of course, it's more typical to have focused vessels. The odds ratio is a little bit lower because you can also see focused vessels, focused branched vessels in a high-risk subtype, but it won't have the well-defined borders or the typically raised topography. And blue pigment was actually more common in nodular BCCs. Okay, and let's look at this lesion. Well, this is a different lesion, or it's topographically flat, right? Completely flat. We do find maybe a few short fine telangiectasias, but they're more difficult to see. The vessels that we see surrounding the lesion are just normal telangiectasias. But we see an erythematous lesion with a lot of shiny white blotches and strands. We see some small superficial erosions, especially at 12 o'clock. and clinically, so BCC, but clinically flat, right? So again, correlating with superficial basal cell carcinoma. So we looked at the features here, and here this in this table you can see that only flat as to the topography has an odds ratio of 10, so very high association with superficial subtype. Ill-defined borders more common, 2.4 odds ratio, and again these unfocused, superficial BCC with the short pine telangiectasias, very typical for superficial basal cell carcinoma. And even though you don't always have more than 4 erosions or 4 or more erosions, if you have multiple small superficial ulcerations or erosions, it's going to be more commonly a superficial basal cell carcinoma. All right, so now let's look at this lesion. We see dermoscopically, we see the typical branched vessels in focus. Branched vessels, we see short fine telangiectasias, we see some blue pigments, right? So definitely a basal cell carcinoma. But then we look at the topography, and is it really? I mean, there's a slightly raised border perhaps, but it's not truly raised, the whole lesion, and it's not completely flat either. We can kind of, put our finger on it virtually and feel that there's some sort of both raised and flat and even kind of depressed in the middle. So this is what we call a bumpy surface. And the bumpy surface is, of course, typical for more high-risk subtypes, the infiltrative BCCs. Okay, and we looked at the clinical and dermoscopic features here as well. And you can see the odds ratios are, around 2, 3, almost 4 for especially the bumpy topography, which is actually the highest odds ratio. Ill-defined borders, 3.4. And then dermoscopically focused vessels, just as the nodular types, of course. So they share this feature with the nodular subtypes. But more typical for high-risk BCCs are the white porcelain areas. We don't see it in this case. We'll see another case within just a second. And vessels within ulceration, which is a new finding. And I'll show you what this can look like. Okay, so here's a case with focused branched vessels and this white porcelain area. So it's basically, I see it kind of like the shiny white blotches and strands that are kind of so widespread in an area that they completely make the whole thing white, the white porcelain area. And of course, ill-defined borders, a bumpy topography, all of this put together make this an infiltrative BCC. Okay, so just one by one, focused branched vessels, and then we have the bumpy surface, and also, just as another feature, helping us, the white porcelain area, making this an infiltrative BCC. Okay, one more case here. We can see that this is a case with focused branched vessels. So already we're suspecting basal cell carcinoma. In the background, we can see the shiny white blotches and strands. But in the center, you can also see that there are vessels within an area of ulceration. Okay, clinically, of course, we have the bumpy topography and widespread ulceration. So, and we look inside this ulceration and we see vessels inside the ulceration, which is different from what we're used to seeing, where we see the branched vessels outside of the ulceration. But seeing them inside the ulceration, this is typical for infiltrative BCC. So this is a finding that we previously haven't described, together with more aggressive cases, but here we can see that it's more common in the high-risk subtypes. Okay, so in the end, we tried to make an algorithm, a very simplified way of knowing whether a BCC is in fact of the superficial, nodular, or high-risk subtype in the facial area. So step one in this kind of two-step process would be recognizing the lesion as a BCC with dermoscopy. And then we go back and we look at the clinical view and we look at, okay, is it flat, is it raised, or is it bumpy in terms of topography? Okay, if it's bumpy, then it's, case closed. You have to suspect high-risk subtype. Whereas if it's flat, well, then you're going to initially suspect the superficial subtype. But if it's flat but also has branched vessels, then something's wrong, something's fishy, right? If it's flat, but it also has white porcelain area or vessels within an ulceration, well, all of these things indicate that it might still be of the high risk subtype. The same thing goes for raised lesions. Raised lesions, initially, you would think nodular subtype, right? But if it's not just raised, but also has ill-defined borders, or if there's a white porcelain area again, or vessels with an ulceration again, the dermoscopic findings that are typical for high-risk subtype, well, then you have to think again and at least consider that it may be high risk. Okay, the sensitivity for this algorithm is quite high, 81.4%. The specificity not as high, but quite good, 53.3%. So it's not perfect, but it really does help in predict high risk subtype better than without any other algorithms available. So let's put it to the test, okay? So here we have basal cell carcinoma. We have the focused branched vessels. We have the shiny white blotches and strands, okay? So we have the features telling us that this is a basal cell carcinoma. Now we go back and we look at the clinical image again. We look at that and try to feel it, try to palpate it. And I would say that this lesion is not flat and not completely raised. In fact, it's kind of in between. It's a little bit of both. It might even be depressed. So we have a bumpy surface. Okay, so already, according to the algorithm, if it's a bumpy topography, then we have to suspect high-risk subtype. And in fact, it was an infiltrative BCC. Let's see one more example. Okay, again, we have the branched vessels, the focused branched vessels. So definitely suspicious for BCC, right? But then we go back to the clinical view and we see that, it's actually flat. So is this then a superficial BCC? Because flat would indicate superficial subtype. Well, we have to just make sure that it doesn't have one of the three other criteria, focused vessels, white porcelain area, or vessels with an ulceration. But as mentioned before, it does have focused vessels. So if you have focused vessels, despite it being flat, then we still have to suspect high-risk subtype. And again, this was an infiltrative BCC. One more case here. This one has lots of branched vessels. They're kind of thinner and less, let's say, classical branch, but we have some vessels that are highly indicative of BCC, and we have shiny white structures in the background. Okay. Now we go back to the clinical view and we see that this one is clearly raised and very well demarcated. So with this topography, then we would of course suspect a nodular subtype. But then again, we do have to look at, do we have ill-defined borders? Well, not really. This one is quite well defined. But do we have white porcelain areas? No. But we do have vessels within the ulceration. So if we have vessels within the ulceration, see the lesion is completely ulcerated and there's vessels all over the place inside the ulceration, well then we should suspect high-risk subtype. And in fact, this was deep infiltrating BCC. All right, so just in summary, suspect high-risk subtype if you have a bumpy surface, okay? This lesion, we look at it, we recognize it as a BCC, and then we go back with the ulceration and the vessels. Then we go back to the clinical view and we feel the lesion and we feel that it's bumpy on the surface. We should suspect an infiltrative subtype or high-risk subtype. Now, even though it might seem relatively flat, if we have ill-defined borders and we also have these focused branched vessels, then we should suspect a high-risk subtype. So again, flat, but also focused vessels, then suspect high-risk subtype. And in a case like this, with not just the branched vessels, but also these white porcelain areas, then also these are strongly indicative of high-risk subtype again. And lastly, here's another case that you can see, which has widespread ulceration, and then we have these focused vessels within the ulceration. So again, a dermoscopic finding helping us to recognize this as a high-risk subtype. And one last thing, which wasn't included in our study because the cases collected at our department haven't been photographed with polarized and non-polarized light, but only with polarized light. Another finding that it's not really conclusive and we don't really know yet, but there may be some indications that this is another feature that can help us recognize high-risk subtypes, was or are the multiple aggregated yellow-white globules, the May globules, as they were coined by Navarrete de Chent, Christian Navarrete, and his co-authors, as you can see here. And what they recognized were these little whitish yellow dots, globules, however you want to see them, or clods if you prefer that term, that you can see in widespread small little white dots and globules throughout this lesion. And you can see them not only with polarized light, but also with non-polarized light. Okay, so these are this is a relatively new finding, newly described finding, and it's due to calcifications within the basal cell carcinoma. And at least in the first publications, it seems to be a feature that's more likely to appear in the more aggressive subtypes. But we have to study this a little bit further in the future. So something else to keep an eye out for. All right. So with this, I thank you for your attention, and I hope you enjoy the rest of the Congress. Thank you very much.
Hello to everybody. Welcome to dermoscopy of atypical melanocytic lesions. My name is Raimons Karls. I am from Riga, Latvia. What you see on my background is a usual view of Latvia in January. I hope the same is also in your country. Where is Latvia? Latvia is a small country in the eastern part of Europe, and exactly from Riga, I'm preparing this talk about the dysplastic nevi. So let's start with a talk about this topic. And here you can see a typical presentation of atypical nevus. What is the atypical nevus? Atypical nevus, we will talk about the next 20 minutes. But from the very beginning, if we are talking about the dermoscopy of these lesions, on the left side, you see a benign lesion with regular network with two colors. And on the right side, you see irregular network, irregular blotches, irregular structures, areas, and quite a lot of shades of colors. So benign on the left, malignant on the right, architecture tends to remain well organized, and opposite, architecture tends to be disorganized. And usually we can say that this is black and white. When we are talking about black and white, if white, network, dots and globules, hyperpigmented structures, streaks and radials, trimmings and pseudopores are regular, are the same in all around the lesion. If we are talking about malignant, network dots, globules, hyperpigmented structures, and streaks have some kind of atypy. They looks different. If we are talking about the architectural disorders, we can say that this is mild, this is moderate, and marked architectural disorder. When we haven't, or it's mild, we are saying it's benign. When we see prominent or marked disorders, we are saying this is true, this is malignant. But in between these two conditions, usually when we have something moderate, and it depends on our experience, we are saying this could be dysplastic. Yeah, and some examples with a typical, more or less irregular, and prominently irregular or marked irregular. So what is the definition? Definitions are different. Definitions could be clinical, definitions could be dermoscopical and also morphological. When we are talking about the clinical definitions, we are saying that there are different names which covers the same topic, like atypical mole syndrome, FAM syndrome, or BK mole syndrome. Here is a slide which shows the differences. It's published in different time, approximately 1970s, the end of 1970s, 1980s, and we see these differences. Here we can see the differences in clinical definition by Cayley and co-authors in 1986, and we see ill-defined borders, irregular distributed pigmentation, diameter larger than or equal to 5 millimeters, irregular borders, and background erythema. Definition given in 1997 by Tucker and others, asymmetry borders, color diameter, and evolving. It's very similar and very close to melanoma. And definition of the Dutch working group, diameter the same O equal or more than 5 millimeters, different borders, asymmetric shape, irregular pigmentation, and again, red hue. So here we can see the slide with a collection of different groups and different definitions. But at the same time, dysplastic nevus and dysplastic nevus, is it the same as precursor? This is a marker of melanoma? When we are talking about dysplastic nevus, we are saying that this is a one individual lesion, and this could be some kind of precursor of melanoma because we are not absolutely agree and we are not absolutely sure about this lesion. And if we are talking about the dysplastic nevus is a marker of melanoma or risk, no, this is just an individual prognosis. Very well known precursor way or the way of development of melanoma. It was introduced by Clark. This model became accepted universally by many, many colleagues, attaining the status of some kind of paradigm. But in nowadays, we must understand that in pathology, dysplasia describes an intermediate state in between benign and malignant neoplasm, which the dysplastic nevus is not exactly. It means that if we are talking about a black and white, it means that dysplastic is something in between, like a gray color. And in nowadays, we can see a lot of publications, and I really agree to very honored person in dermoscopy, Professor Harald Kittler, that in some kind, dysplastic nevus, this is a term which could be even abundant in dermoscopy. So if we will turn our attention to very easy things like Atlas of Dermoscopy by Ashmar Hoop, we can see the different patterns which could be found in a nevi. We can find also different patterns which could be found in melanoma. But the question is still the same. Dysplastic nevus is a source of melanoma or it's a precursor of melanoma? In clinical, is clinical atypia synonyms to with histologic dysplasia? So regarding the atypical nevus as clinical term, why dysplastic nevus is a histological or pathomorphological term? So let's not miss these differences. Let's not to mix them into the same category. So there is a quite poor correlation in between clinical atypia and histologic dysplasia, and this is evident. Again, we see different types of patterns in benign melanocytic lesions, and we can put them in or collect according to our knowledges that this, what we see on this slide, yeah, this is patterns which are typical for acquired nevi, acquired dysplastic nevi, and Spitz nevi. Another one, this is a dysplastic nevus. And next one, this is a Spitznevei or Spitzoid nevi. What we know from result of studies on autopsies, there is at least approximately 10% of nevi which could be dysplastic. And another one study shows that prevalence of dysplastic nevi could be up to 50% in Caucasians. Let's turn to the basics of dermoscopy and we see the morphology of nevi. We see cobblestone pattern, we see globular pattern, we see reticular pattern, we see homogeneous homogeneous blue, homogeneous brown. We see starburst pattern, and we see non-specific pattern. Again, if we will turn to this concept, we can classify our nevus according to this. Distribution of the pigment, it could be also different. It could be central and hyperpigmented. It could be uniformly hyperpigmented. It could be multifocal hyper or hyperpigmented, central hyperpigmented, eccentric hyperpigmented, or eccentric hyperpigmented. Colors, there are different colors of nevi, and as we see here, it could be also light brown, dark brown, it could be black, it could be blue, it could be, it depending on the depth of location of the pigment. It could be also white, like these whitish structures in these balloon cell nevus. It could be red, and also it could be gray. This is the main colors which we see usually in nevi. Another one, of course, this is for better understanding what is dysplastic nevus, is a classification of the melanocytic nevi by two main categories, congenital nevi and acquired nevi. Congenital nevi we can subdivide by size, large, intermediate, and small. And acquired nevi could be junctional and compound on dermal by morphology. They could be with a spitzoid pattern, they could be blue pattern, or neosteroleus, and others, like special conditions. Yeah. And here, of course, for congenital nevi, we are talking about the nevi with a pigmentation, with a uniform pigmentation, or hyperpigmented areas. And we also can talk about the congenital nevi with hypertrichosis, perifollicular hyperpigmentation, and also the presence of vessels. Let's take a look for some examples. Pigmentation, it could be uniform, more or less uniform, more or less uniform, and this could be not so equally disturbed. It could be hyper or hyperpigmented, also could be hypertrichosis with the hair growing of the terminal hairs, perifollicular hyper or hyperpigmentation, and presence of some vessels, which we could see especially in the globules or papillary structures, and in some instances we also can see in the flat part of the nevi, but this is not typical finding. So, of course, we very well known about the age-related prevalence of dermoscopy patterns in acquired melanocytic nevi, and of course, we are talking about the globular pattern in the nevi, which are typical for the childhood. We are saying that globular nevi, this is previously categorized as a small congenital nevi or combined nevi plus minus dysplasia and dermal nevi, and this is lifelong persistence. We're talking about the reticular pattern, and this reticular pattern correspond to proliferation of melanocyte along the elongated retroregis, and usually we see in junctional nevi. And when we are talking about reticular nevi, we are saying that this is not a congenital, but this is an acquired melanocytic nevi. And usually we are also observe the disappearance of these nevi during the lifetime. Reticular nevi, previously categorized as acquired melanocytic nevi or junctional nevi, development due to exogenous pathways, and finally we are talking about the involution during the lifetime. Starburst pattern corresponds histopathologically to vertically arranged well-defined junctional melanocytes. We are saying that this is a fast-growing nevi, and usually we are saying that there are two types. This is a Spitz or reed nevus, of course, with some stories about the intermediate stages like atypical Spitz nevus or something else. But we say that these lesions undergo some stabilization and finally also could undergo involution. Blue nevi with a homogeneous pattern, blue nevi, previously the same. We know that this is a blue nevi for a long time, and this is persistent nevi, and there are no changes during the lifetime. Next, there could be, according to the special features like macula and papillary lesions, like a combined nevus, like a halo nevus with some features of regression, hemosiderotic targetoid nevi, Mersenne nevi with an eczematous reaction, and recurrent nevi, especially very often found after some incomplete removing of these lesions. Unclassified melanocytic lesions, they could be with different patterns. They could be globular, reticular, starburst, or blue. Site-related, like a facial, like a acral, like a subungual. And finally, when we are talking about some dermoscopic features which are not clearly defined into one category, we are saying that we need to rule out melanoma. So when we are talking about the melanocytic terminology, there are a lot of these controversies, and especially in nomenclature, and also when we are giving the name to different conditions, and when we try to say that this is a highly suspicious lesion, we are saying that this is something like a dysplastic nevus. So, but what is dysplastic nevus in reality? Dysplastic nevi, we see a patient with a multiple nevi. Usually these nevi have a size of more than 5 millimeters and clinically present and looks like melanoma. And in this current patient, we see the front and dorsal part of the body, and we can say, yes, there are a lot of lesions which could be melanomas. As I already said, it could be precursors or maybe risk factor of melanoma. But what we see dermoscopically, we see that usually these lesions have patterns, mixed patterns of network and homogeneous structures. They could have some vascular lesions. That's why clinically they have this pinkish hue. We see dotted vessels or maybe some curved vessels, especially in the central part. We can see some whitish areas, small whitish structures. We can see some hyperpigmented areas in these nevi, but usually they are located centrally or eccentrically. The same as in this case, we see a nevus with a combination of balloon cell and also present of some pigmentation. Papillomatous structures in the center with the vascular structures and pinkish hue. Again, network at periphery, globules or even homogeneous structures or cobblestone patterns in the center. And finally, we can see homogeneous areas with some areas of negative network, like here. And all this belongs to the spectrum of dysplastic nevus. So again, in some patients, we also can see this peripheral rim of globules as a feature of the drawing. And finally, the dysplastic nevus is just a nevus? No, it's just a large acquired melanocytic nevus. Usually we are saying that this is benign, and by definition, there is a diameter more than 5 millimeters, and the flat part is obligatory. Management, usually for dysplastic nevi, is follow-up of the patient, not the excision, but follow-up. Clinical and dermoscopical follow-up. When follow-up, clinical, dermoscopy, excision. And of course, we also need to understand, is this lesion belongs to this group of acquired nevus, this Clark nevus, or malignant melanoma. And in literature, we can find a lot of data about the dermoscopy of classification of atypical melanocytic nevi, as we see here. And as you also can find, this is a more than 20 years ago published data by Rainer Hoffmann-Wellenhof and co-authors. So in nowadays, when we are talking about the dysplastic nevus, we must understand that this is a large acquired nevus with a dermoscopy classification by structural features, reticular, pigmented globules or homogeneous pigmentation. These nevi could have eccentric periphery. They can be multifocal. They could be central with hyper and hyperpigmentation, with reticular, predominantly with a reticular pattern, reticular homogeneous, globular homogeneous, and reticular globular patterns. And more than half of all patients could have them. And usually these patients also have one predominant type. Another one, data about the dermoscopy of patients with multiple nevi and how to improve the management of these patients. So how to improve? We are doing a clinical follow-up. We are looking for the new lesions or lesions who undergo some changes. Then we are going to dermoscopy. And of course, a digital dermoscopy is a very helpful for the management of these lesions. So, hope you find this lecture fruitful for your daily practice. And at this moment, I would like to say thank you for your attention and hope you will enjoy this beautiful meeting organized virtually. And see you soon, very hope, on site.
Hello, my name is Katarzyna Korecka. I'm a dermatologist. I work at the Department of Dermatology of Poznan University of Medical Sciences, where I see skin cancer patients and I share my passion for dermoscopy. Thank you, Ibrahima, for inviting me to this amazing event. It's a great honor to be a part of this wonderful lineup. And today I'll be speaking on dermoscopy and Merkel cell carcinoma, which has been an interest of mine for the past 2 years, and I will explain to you why. So if we go to PubMed and search for dermoscopy, you will find around 10,000 searches. So that's quite a lot. And it made me think whether there is anything new we can find in dermoscopy. And I will leave you with that question until the end of this lecture. In terms of non-melanoma skin cancer, if we ask our residents, for example, whether they know any BCC features, they will say like, yeah, easy, like arborizing vessels, blue ovoidness, and so on. So that's quite known. And generally after one dermoscopy course, people are really, really familiar with some of the most common cases and features. In terms of SCC, it depends. We have a paper coming up on difficult squamous cell carcinomas, but the white circles, keratin, they're quite known, and recognizing most of the tumors is also not as difficult as we think. However, when you go to Merkel endermoscopy, like if we ask dermatologists at Congress or at any other events if they know any specific features for Merkel, I think the answer would be quite difficult. So, do we really have any rules for Merkel? I'd say if it's pink, stop and think by a famous Italian professor, Geppi Argenziano, because Merkel is usually a pink tumor. And second of all, never follow up nodular lesions. If you cannot name it, if it's a pink tumor nodule, you cannot name it, better excise it, just not to miss Merkel, which is an aggressive tumor, right? So never follow up nodules, just excise if you cannot name it. If it's benign, it's not a mistake. If we go to PubMed, and this is the search that I did this morning right before recording this presentation, we find 33 records. So that's not really too much. And I remember doing this a while back too and thinking, wow, we can do better. So what do we know so far? We have 68 cases available, with the biggest case series being in British Journal of Dermatology in 2014. And this still remains the biggest case series published. There are no studies with control group. So why is that? Why we know basically nothing on dermoscopy in Merkel, not too much. First of all, I'd say outside of some of the referral centers or centers that are really interested in spreading the dermoscopy knowledge, people don't really take a lot of pictures of what they excise. We talk about it a lot, but I feel like this is still an issue. Second of all, sometimes Merkel's get misdiagnosed, for example, for basal cell carcinoma. So people just see it and like, okay, it's a BCC, whatever, just excised or LEGO and then they receive a pathology result saying it's Merkel. And while we can retrieve pathology slides, it's really difficult where the lesion is excised. You cannot go back. The tumor is gone, so there is no way to see the dermoscopy picture. And third, Merkel is a rare tumor after all. So this is also one of the reasons why there's still not much knowledge about it. Like if you are a skin cancer doctor, you will see plenty of BCCs within a week, few SCCs maybe, and melanoma is not as frequent too. So where Merkel is super rare, you don't really see it that often. So recently, this is a paper that was published in October 2024. We did a review. We did a review on all the non-invasive skin imaging in Merkel cell carcinoma, and this is actually, I'd say, quite nice paper that I was a part of with Emilius and Caterina Longo and our colleague Julia Badiu from Bucharest, Romania, where we summarized all the knowledge available on Merkel's presentation. And of course, dermoscopy, but also confocal, ultrasound, OCT. You are free to check it out when you get a chance and if you are interested. And here's a table that we created for dermoscopy features of Merkel's. So there is a prominent red hue indicated blood vessels, milky red areas and vascular anomalies, pink structureless areas, white areas, scales, hyperkeratosis, vascular morphological structures, arborizing branching vessels, which I'll be talking about in a moment, and lack of pigmentation or blue-gray veils. But this is actually the best paper available right now, which was out this summer. So actually it's the best on dermoscopy because it's comprehensive, really great review by Amelia's group on features that are described in available literature, very detailed, and this is the paper that I actually based this presentation on. So what's the most commonly described feature of Merkel? Milky red areas or pink structureless areas. So sometimes people ask me what's structureless. So basically, structureless areas are areas in this picture of a lesion where you don't see any structures and they're pink. So that's quite, I'd say it's quite simple. They were present in 72% of the lesions, which means 39 out of 68, which is a quite great number. And we differentiated with pyogenic granuloma, amylolytic melanoma, vascular lesions, or inflammatory conditions. So as I told you, usually red or pink tumors, pink nodules that cannot be really diagnosed clinically or are difficult to diagnose clinically. Here you have an example of pink structureless areas. Pink structureless, as I told you. And here's another example where I put an arrow just to show you the pink structureless areas that we are talking about in a Merkel cell carcinoma. Here's an example from a paper from 2012 from Luc Thomas' group. This is a lesion on a buttocks. You see some pink structureless areas or milky red background, as some call it. Red dots seen in this lesion in dermoscopy. So as some of you know, or all of you know, we have our own Wikipedia in dermoscopy, and it's called Dermoscopedia, and I really love it, and some of the pictures that are there are quite great, and I use them also in this presentation. So you see some different vascular patterns that can be seen in Merkel's, starting with linear irregular vessels, which are the most commonly seen. Arborizing vessels, and these are the two types of vessels that are the most difficult to differentiate between each other, and we'll try to find some differences. Polymorphous pattern, easy, you get a few subtypes of vessels, so comma vessels, linear irregular, arborizing, branching, dotted, all together. If you see a few types of vessels within a lesion, then you can call it polymorphous. Dotted vessels usually associated with melanotic melanoma, which is the most, I'd say, differential in Merkel's. So these are the two diagnoses that sometimes are difficult to really differentiate between one another, and pathology is the one that helps us, especially in melanotic melanoma and glomerular vessels. So here's an example of linear irregular vessels in a paper from 2012. You see these linear vessels that are distributed irregularly throughout the lesion. But compared to arborizing vessels, which I will show in a moment in BCCs, they're not forefront. They're within the lesion, but not really that forefront. Here's another example from Emilia's paper from 2014. You see these linear irregular vessels distributed throughout the lesion. And here's another example of linear irregular vessels throughout this nodular pink lesion in a paper from 2016. And just to compare with arborizing vessels from BCC, from our archive, you see these prominent forefront linear vessels with thin branching vessels. So this is a typical picture from a BCC, but can be also seen in Merkel, as you see in this picture. Thank you, John Pauli, for letting me use it. I really, really appreciate it. And here we have polymorphous patterns. So as we mentioned, if you have a collection of different vascular patterns throughout the lesions, always think of polymorphous patterns. So you maybe see some linear here. If we look closely, there are some maybe dotted vessels and so on. If you see few patterns, just call it polymorphous. And here as well, polymorphous pattern from a paper from 2010. Maybe some comma vessels, maybe some linear regular, some dotted if we look closely. So you see some different patterns. In very similar case, you see some thick vessels, maybe some linear regular, maybe also, if we look closely, some dotted ones as well. Polymorphous pattern. An example of dotted vessel from Christian Navarrette's paper from 2021. This is a lesion on the face with dotted vessels. So you might suspect a melanotic melanoma here, or maybe inflammatory condition, because they are also seen there. So you have to be very careful when you see an erythematous lesion in a skin damaged skin, because Merkel should be somewhere at the back of your mind, and sometimes it's better to take a biopsy, especially if the lesion is not healing. Another example of dotted vessel from this plaque, or maybe this erythematous plaque from a cheek, in a paper from 2012. And in the center of the lesion, you can see very clearly this dotted vessels. Glomerular vessels are usually associated with squamous cell carcinoma in situ. However, we do have cases in literature when we see Merkel's in collisions with SCC in situ. And actually, in our IDEA study, which I'll be speaking about in a moment, we do have such cases too. So sometimes it's quite difficult to differentiate between these two entities, because they all occur also on sun damaged skin. Lacunas, which are clusters of numerous well-defined round or oval reddish formations, which are divided by septa or a white rim, usually associated with vascular lesions or pyogenic granuloma. As you see, it's not actually very frequently seen in Merkel. This is a nice image from Dermoscopedia that really visually shows the idea of lacunes. And this is an example. You might think it's a pyogenic granuloma. You see some septae. However, this is why we like our pathology results in pyogenic granuloma, especially when you see some maybe vascular patterns within the lacunae. Here you also may see some rainbow pattern as well. So this is a very unusual lesion, and in these kinds of lesions, it's better to get a pathology result. Here's another lesions when you might see a few lacunae. Also unusual pattern are Merkel cell carcinoma. Ulceration is usually associated with a BCC, but it actually can be present in any malignancy because it corresponds to loss of epidermis due to tumor formation. As you see in Merkel, it was not as frequent, but it might occur. This is just an example of an ulceration in a BCC, so very, very typical presentation. And here an example of Merkel with an ulceration, also courtesy of John. Thank you very much. We also see scale in Merkel. You might see white scale, which is usually associated with inflammatory conditions such as psoriasis, lichen planus, and so on, and yellow crusts, which are results of serum extravasation or as a result of serum mixed with keratin. So, for example, in dermatitis. And here is an example of corticeoid familius in Zoe with a yellow scale, and that this is a Merkel cell carcinoma. White lines usually seen in your polarized light, so please use your polarized dermatoscopes just to help yourself to see these structures are usually associated with melanoma, but we do have shiny white strands in basal cell carcinomas. We might see white lines in Spitz tumors. We might see white lines in dermatofibromas. So basically, it's important to assess these kinds of lesions with clinical context and to adapt all of the other features. And this image is courtesy of Professor Nisa Akai, who's amazing, and thank you very much for allowing me to use it. So this is a pink tumor with linear vessels and shiny white lines. So it does not add up really. This morphology is quite difficult. We might say it's a BCC, but we are not sure, and we excise it. Therefore, we get a diagnosis of Merkel cell carcinoma. Structurous areas, as we already discussed, they might be they don't have to be pink structureless, but they may feature hyperpigmentation, regular pigmentation, and so on. And they were present in 13 out of 68 Merkel cases. And just to sum up, there's this nice graphic featured in a paper from 2014. This is the biggest case group that we have available in the literature right now. And it shows this nice graphics of the dermoscopy features in Merkel, irregular vessels, arborizing vessels, shiny white areas, and milky pink areas, or in one graphic. It's very memorable, and it helps you to memorize some of the features that we have just described. So why I am speaking on Merkel? Because we are doing this IDS study on MCC features, which is a multicentric study. Of course, the primary investigator is our president, Professor Emilio Lalas, and I am the coordinator. And we aim to find the most frequent features of Merkel cell carcinomas. And we featured a control group, which consisted of tumors with similar clinical morphology, non-pigmented, non-hyperkeratotic nodules, and we asked our participants to submit to control cases per one Merkel. This is the primary result that we have received. So we have 127 cases of Merkels from 122 patients, so there are few recurrences or metastases. Approximately 260 control cases, 64 females, 64 males, 58 females, with a mean age of 76. And the most common locations were the face and the lower limb. So as you're listening to this lecture, we are probably in the process of assessing the images, because while I'm recording this, we're actually starting this. The analyzed features that we wanna look for are structureless areas: pink, red, yellow, and white. Different vascular patterns that I have just described for you, red clots and globules, scales, and ulcerations. If you have any questions, feel free to ask me, and I wish you a great day and amazing Congress. And I hope you enjoy all of the sessions. Thank you for having me again, and I look forward to seeing you all also in real life. Thank you very much.
Dear colleagues, so I will be presenting now dermoscopy and surgery of the nail unit through 3 different clinical scenarios. I'm Nourdin Litaim, I'm a dermatologist from Tunis, Tunisia. I've specialized in dermoscopy, dermatologic surgery, and nail diseases, and these are my affiliations, and I have no conflicts of interest to disclose in association with this presentation. And in this presentation, the slides are written in French, and I will be presenting in English. This choice was motivated by the fact that I know quite well that many parts in Africa are more comfortable in French than in English, but to reach a larger audience, I will be presenting in English, and I'll be showing my slides in French so that everybody could understand what's written. And I will start by the first clinical scenario. So, These are two patients, quite the same age. 20-year-old here, 23-year-old here on the left, and the patient on the right has a past medical history consistent with bone marrow hypoplasia, and she was receiving medication, L-Trombovac and cyclosporin, and she has this lesion on the hallux that was evolving for 4 months. And on the left, quite the same age, 23-year-old female patient, no past medical history, however, and she reported that this lesion was present for 7 months. So, do you think that both those patients had the same diagnosis? Do you think that this is the same? And what would be the investigation you would do here in both those patients? So let's start by the patient on the right. And I think here the diagnosis is quite straightforward because she was receiving medication that would be responsible for the appearance of pyogenic granuloma. And was indeed a case of pyogenic granuloma that was confirmed by histopathology. And here you see images from the literature. And here, and as you know, that pyogenic granuloma beneath the nail plate usually present by granulation tissue, oozing, sometimes pain, and trauma usually precedes the appearance of the lesion, but many medications are involved, and sometimes the traumatic factor is missed or maybe not reported or inexistent. And here you see the dermoscopy of two pyogenic granulomas on the skin, and here you have these clots, red clots with these white lines, and here you have this proliferation with this very suggestive keratotic colorette around the lesion. And here an image of a pyogenic granuloma beneath the nail plate, and here you see this white aspect around the pyogenic granuloma, and when you put your dermoscope you could see quite well the white colorette. And here tangential excision would lead to good results. And here another case of a pyogenic granuloma beneath the nail plate in the hyponychium, and you see the colorette here, you see the proliferation, and here is a clot related to the existence of a hemorrhage preceding the image. And in this patient, topical application of corticosteroids led to good results. So, the case on the left, a pyogenic granuloma. Do you think that the case on the left is also a case of a pyogenic granuloma? So, when you are in doubt, what would be the first examination you would perform? And as a rule of thumb, every time when we have a proliferation beneath a nail plate that comes from beneath, it is useful to have an X-ray to see how it works with the bones. And here is the X-ray of this patient. And sometimes you have a report that says that the X-ray was normal. And of course, it is not normal. Here you see that it is something. And the incidence of the X-ray is very important because in 3/4 incidence, you have this quite beautiful image, very, very suggestive of the diagnosis. So here it is clear-cut a case of exostosis. And here, the surgical excision of the tumor. So sometimes you could suture the nail bed, sometimes you would leave it healing by secondary intention. And here the lesion was left healing by secondary intention. This is an image at day 10 post-operatively. You see how it heals quite quickly, especially in the young patients. And here after day 45, in this patient, and usually this surgery leads to good results, and the only thing that would persist is a distal onycholysis that may be persistent, like a sequela of this intervention. But yeah, let's move on now to the second clinical scenario, and also two patients. On the right, a female patient, 59-year-old. She had this lesion for 2 years, and the nail was asymptomatic. On the left, a 67-year-old male patient who had a pain and swelling of the hallux, and he has this aspect on the nail. So, do you think that those two patients had the same thing, the same diagnosis or not? And let's see how the dermoscopy would help us. Let's start by the patient on the right. So here you see the dermoscopy. And here you see clinically what's left from the nail plate, this part of the nail plate. And here, even if you are not that comfortable with dermoscopy, when you see the tissues, fibers, dust, etc., that are apparent, you are on the lesion, you are quite sure that this is a huge ulceration, that this lesion is ulcerated. And this patient had a pemphigus. Her her skin lesions healed nicely, and only this nail involvement did not respond to corticosteroids. It was quite refractory, and it necessitates the injection of corticosteroids, triamcinolone. When it comes to pemphigus, here I'm showing you the results of two series. On the right, a series from Tunisia, in which I was involved, and on the left, a series from Morocco. And I'm showing you these two series because pemphigus is endemic in North Africa, especially the Maghreb region, and we have many cases of pemphigus. And what's striking is that we have quite the same results in those two series. Here, 48 cases on the on the right, the series from Tunisia, and in Morocco, 37 patients. And the most frequent signs of pemphigus on the nail are onycholysis, pyronychia, um, and um, and sometimes you have other signs like onychomatosis, Bowes lines, blisters, periangle, and hemorrhage. And these are the most frequent signs. Let's see now the patient on the left. This is the picture I showed you before, and this is the image of the hallux. What is striking here on the hallux here is the swelling of the whole digit. So this is a case of dactylitis. So what would be the diagnosis? Let's think a little bit about it. The patient had nothing, no other clinical, the clinical examination was otherwise unremarkable on his skin. So what would be the diagnosis here? I think that many of you think about psoriasis, and they are correct. So this is a psoriatic onychopachydermal periostitis, and the patient received initially methotrexate up to 25 milligrams per week with small results associated with injections of triamcinolone with a temporary result, and then he received infliximab with good result. And you see here another patient from the literature, and here the patient received infliximab and methotrexate with good results. And sometimes when you would like to perform an ultrasound imaging of the nail, and I would like to show you, so this is a paper we published in 2020 about the ultrasonographic examination of the nail. And you see here, just to show you a normal nail. So the nail is this kind of three layers of hyperechotic layers on the dorsal aspect and on the ventral aspect. So this is the nail plate, and here is the nail bed, here is the bone, so here is the matrix. And you see here, so this is the tissue beneath the nail plate, so this is the nail plate bed, this is the matrix, and here is the bone. And these three layers are very important in a normal healthy nail plate. And when you examine the nail plate itself in psoriasis, given the inflammation, the first thing that appears is a blurring of these three layered architecture or aspect. And it's the ventral aspect that becomes hypoechotic, and then the whole nail plate eventually would become depending on the intensity of the inflammation. So this is something quite nice you would like to perform if you have ultrasound available. Now let's move on to the third clinical scenario. And also I'm showing you two patients. The patient on the right and on the left both had painful lesions that appear red. And what do you think? What would be the diagnosis? And I think most of you would suggest the diagnosis of glomus tumor. Let's see the dermoscopy on the first patient. So here you have this violaceous pinkish background with this arborizing or these arborizing vessels that you see here, some dystrophy on the nail on clinical examination. And it was indeed a case of subungual glomus tumor. And this is maybe one of the major articles describing dermoscopy of subungual glomus tumors. It's from our friend Fatih Koktay, and it was also Professor Eckhart Haneke is among the co-authors of this article. What this article shows is that there are maybe two patterns. The pattern of the glomus tumors that are beneath the nail matrix and those that are beneath the nail or on the nail bed, like as you see here. But quite interestingly is that the dermoscopy would help you see features that are not visible in naked eye examination in 10% of the cases. And sometimes dermoscopy will show nothing. And this is published in the Blue Journal in 2016. This case, you see here quite nothing, only pain is, and the love pin test is also positive here. And you see this is related to the glomus tumor beneath the nail matrix in the part of the nail matrix that is not visible here. So this patient has a glomus tumor and we performed surgery, and I start by the avulsion of the nail plate, and the incision is of course performed here because the tumor is very big, parallel to the lunula as you see here. A gentle, very gentle dissection of the tumor is important to remove this nodule, not to leave the part of the glomus tumor. Otherwise, we would have a recurrence. So very important to be very gentle. And you see here, post-operatively, this is the tumor. And here we suture the nail matrix. Of course, we put back the nail plate. And here after the result after day 7, this is after 2 months, this is after 5 months, and this is after 8 months. And you see how the nail is healing quite well. Now, when it comes to this second patient, do you think this is a glomus tumor? So in this patient, I have doubts because usually with glomus tumors, we do not have this dystrophy on the nail, and the Lupin test was negative and the pain was different. So we performed an ultrasound and it was a case of myxoid pseudocyst. I'm not diving into the details, but just to tell you that there are 3 subtypes. The type A here, very obvious. The type B, quite tricky, but you see the groove. And the type C, that is the trickiest, which is beneath the nail matrix. And many treatment options are available. And I think that puncture, iterative puncture and drainage of the myxoid pseudocyst is reasonable alternative as a first line. And when there is no result, then we can go to surgery. And here a type A glomus tumor here, we see the dermoscopy, and here after multiple punctures we don't have a good result. So I performed this the excision of the lesion and the flap, transposition flap, and we see here the aspect after 3 months, and here you have the same patient after 6 months, and no recurrence was seen after 2 years. And here another case, the type B now of myxoid pseudocyst, and you see here the groove irregular, so this is a sign that is suggesting the diagnosis of pseudocyst. And a tricky thing is to inject a methylene blue into the joint, and you see the communication between the joint and the lesion, and you suture it, and you put back the flap, and yeah, it would lead to good results. So If you are interested by other cases of nail surgery, it is good to, if you want to visit the videos that we posted, the surgical group from the Tunisian Society of Dermatology, and these are my videos on YouTube, so you can check it out and visualize those videos. And of course, for nail enthusiasts, the major educational event would be on February 8th, 2025, the same platform. All you have to do is to scan this QR code here, and that would lead you to the Global Dermatology website and to the event website. And more than 59 nail experts would give wonderful talks about different aspects of the nail. So for nail enthusiasts, this is the biggest event, and I would thank the nail societies that supports this event: the International Nail Society, the European Nail Society, the Council for Nail Disorders, Nail Society of India, and Korean Nail Societies, and more societies, including the African Society and Tunisian Society of Dermatology, that support this event. And with this, I would like to thank you very much for your attention and hope to see you soon in Tunisia.
Hello to everyone. It's a great pleasure to be here. I'm very happy to join this very big event, and thank you very much to Ibrahima for the invitation. Today, I will speak about dermoscopy of infectious dermatosis. They are pretty much common in daily practice, so it's very helpful to know dermoscopic features of these conditions. And sometimes dermoscopy may allow us to make the diagnosis without any other expensive tests or examination. These are my conflicts of interest for this presentation. And this is a commentary that I published a couple of years ago. And at the beginning, dermoscopy of infectious diseases was identified with dermoscopy of parasitic infections, and indeed, the terminology used at the beginning was entodermoscopy or entomodermoscopy, which refer to parasitic infections. But actually, over the time, many authors published dermoscopic papers, dermoscopic studies on infectious other than parasitic diseases. As you can see in this slide, this is pretty much updated, and we have more non-parasitic infections having at least one dermoscopic description compared to parasitic dermatosis. So I propose to change the terminology from entodermoscopy to infectioscopy, which in my opinion is much more correct. We know the main conditions from a dermoscopic point of view. For example, warts. We know that in warts we have this mosaic-like appearance, these thrombized vessels, these black spots, black dots. In molluscum, we have a typical appearance characterized by these white bright globules. Okay, in leishmaniasis, which is another famous dermoscopic description in infectious fields, we have follicular plugs or are orange background and focused vessels. We have also parasitic infections. For example, in tungiasis, the main clue is the presence of this central pore, which is the genital opening of the parasite, and we have this roundish structure, which is the abdomen of the flea. In furuncular meiosis, we have pretty much characteristic feature, which is this bird feet-like structure in the center, which represents the presence of breathing spiracles. And we also have these brown dots at the periphery, which are the spines over the parasite body. And then we have demodicosis with these protruding follicular plugs, which represent a mixture of hyperkeratosis and mites. But I don't want to focus on these conditions because they are pretty much well known for dermoscopic experts. But I would like to give you something new. For example, here we have a case of an infectious disease, which is tinea capitis, of course, This is a clinical diagnosis in this case, but we also have some dermoscopic clue which may make the diagnosis easier. We have the C and S-shaped hairs, as you can see here, corkscrew hairs, and band hairs. These are all features characteristic of tinea capitis, but the diagnosis is not the point in this case. Of course, this is tinea capitis, but these are the features as I showed you. The main clues are the presence of, let's say, this corkscrew-like hair and S-like hair, which are the most characteristic features besides Morse code hair, which are not displayed here. Okay, here there is an example of Morse code hair. So these features highlighted in green are the most specific features of tinea capitis. But as I told you before, the diagnosis is not the point in this case. I treated this patient with griseofulvin, 15 milligrams per kilogram daily for 6 weeks, and after 3 months, this was the result. So now I had to decide if the patient was healed or not, and this is an important assessment when we follow patients with tinea capitis treated with antimycotic therapy. Okay, from a clinical point of view, I would also say, okay, it's fine, the patient is healed. Let's take a look at dermoscopy. What do we have? I don't see dystrophic hair. I just see a little bit of scaling, white scaling, but actually there is a nice study made in Brazil uh, a few years ago saying that when we have the disappearance of dystrophic hairs, okay, we can be pretty much sure that the mycological examination would be negative. So if we don't have dystrophic hair, we have to consider the patient healed, okay, according to this study. So what did I do? Okay, I said the patient, you are healed, you can go home. Okay, perfect. After 3 months, the patient came back to me with this picture, and there was a little bit of scaling, not dystrophic hair, so I didn't know actually, but I used a new device that I had, which is the UV dermatoscope, and what I saw is this: we had green fluorescence, and green fluorescence means that the infection is still active. Okay, UVF dermoscopy and tinea capitis may show green fluorescence even if we don't see dystrophic hair. So even in very early stages or in case of an early recurrence. But this is true just in microsporum related instances, okay? Because as you know, in trichophyton related infections, we don't see fluorescence. So this finding is very helpful in very initial stages and in the follow-up of the treatment. So this is another very important question, which is the optimal treatment duration in tinea capitis. Basically, if we see the guidelines, the books, this is the treatment range, 4 to 8 weeks. Okay, but here we have 2 patients. So what do we have to consider when we choose the treatment duration? For example, in the patient on the right, we have a very extensive picture. On the left here, we have just a single patch. So I would say we should be much more aggressive and longer in the case on the right, apparently, because it's more extensive. But if I show you that the one on the left is due to microsporum and the one on the right is due to trichophyton, the answer would change. Why? Because when we have microsporum, we usually have a nectotrix infection. So the fungus grows outside the hair shaft. When we have trichophyton, the fungal infection is inside the hair shaft. So this means that the endotrix infection is less contagious, um, and it needs a shorter therapy duration because the medication may reach the fungus much more easily. On the other hand, when we have ectotrix infections, so microsporum related infections, we have a higher tendency to infection spreading, of course, because the fungus growth is outside the hair shaft. We have the need of a longer treatment because the medication given orally um, may have much more difficulties in reaching the fungus. And of course, we also have a better response to grisofulvin. On the other hand, in trichophyton infections, in endotrix infections, we have a better response to terbinafine and imidazolic medications, such as itraconazole. Okay, so the question now is it possible to distinguish microsporum from trichophyton related tinea capitis on dermoscopy? We have this study. This is actually a review, so including several studies, and this paper said that if we have corkscrew hair, we have to think about trichophyton. If we have zigzag, bent hair, and Morse code-like hairs, we have to think about microsporum. But these are some examples. Corkscrew hair, typical of trichophyton, according to this paper. When we have bent hair and, especially Morse code-like hair, we have to think about microsporum, so ectotrix infection. But actually, as I showed you before, this case, my case, this was due to microsporum canis, and we had corkscrew hair. So on polarized dermoscopy, it's not easy to differentiate microsporum from trichophyton infections because there is an overlap. Okay, so there is an overlap, and we cannot rely on polarized dermoscopy. We did a study, and what we found is that microsporum related infections always in active stages, of course, show green fluorescence. Okay, trichophyton infections do not show green. So this is the major point of differentiation between these two types of infections. So let's move to something else. Of course, here the diagnosis was pediculosis capitis. Okay, so we treated this patient with topical pyretrins day 1 and day 10, and this was the result. So the question now is, okay, is the patient healed or not? We can say yes, because this is dandruff. We can see that the dandruff is very bright, white bright, is irregular in the shape, in the outline, and the scale envelops the hair shaft completely. Okay, so it's healed. What about this patient? We treated the patient, did the treatment at day 1, 10, 20, and 30 because she was not sure, so she exaggerated with the treatment. And what we saw were these structures. This is a magnification, and we have this jelly tubular structure enveloping the hair shaft. So still the patient is healed because these are hair casts due to the irritation of the treatment. Healed. What about this patient here? Do we have nits? I would say yes, we have nits because we have this oval structure light on the sides of the hair shaft. Okay, but is this vital or not? So is the patient healed or not? This is the magnification. So basically we have three types of nits: viable nits, non-viable nits, and empty nits. Empty nits is very easy to recognize, because we have a flat ending, and of course the nit is empty. Non-viable nits and viable nits, both of them have the cup, but viable nits are brown, homogeneously brown. Non-viable nits contain some hair bubbles. So we see an irregular brown structures inside. So it's the same basically for pediculosis of the pubis. So we have viable nits, so the cup and the brown homogeneous color. We have non-viable nits, so the cup and non-homogeneous brown pigmentation. So what about this case? In this case, we don't have a uh, complete cup, and we don't see how homogeneous brown pigmentation. So these are not viable nits. So the patient was healed. What about this patient? Let's see dermoscopy. What can we see here? We have a papular eruption, but on dermoscopy we can do the diagnosis because we can see this triangular brown structure with this gray serpiginous tract. So this is of course scabies. Scabies is very easy to diagnose on dermoscopy because of the presence of the anterior part of the mite appearing as a brown triangle, and we have this serpiginous white tract, which is the burrow. Okay, this is fantastic. Okay, but I would like to show you this case. This was a very itchy eruption. Okay, and this was dermoscopy. What do we have? We have a lot of white and yellow scaling. So the first impression here would be eczema, and of course this is eczema, but we also have something else. We have this, let's say, brown triangles, but without any burrow, because in this case you can see here the brown triangle, okay, like aircraft, which is the anterior part of the mite. So this is scabies. This is crusted Norwegian scabies, and in this case, in crusted scabies, we don't see usually the burrows because we have a lot of scaling which cover the underlying burrows. You can see another case of Norwegian crusted scabies, and we just see a lot of brown triangles without well-formed um, burrows. Okay, let's see the prior patient. We treated this patient with several courses of ivermectin given orally, and this is the results. Basically, we can compare pre and post treatment, and we can see that in post treatment image we just have an amorphous structure, but not the brown triangle that we could see at the beginning of the treatment. So if we use our dermatoscope and also our smartphone, we can zoom a little bit and see that we don't see well-formed mite. What about scabies in skin of color? Basically, in this case, we usually don't see the triangle, the anterior part of the mite, because in skin of color we have a lot of melanin exfoliation and crusting. So let's say the mite is not very well visible, is hidden under the melanin and the crusting. So we have to rely on the presence of the burrow. But what about this case? This is a very high phototype 6. Could this be a burrow? Maybe, but it's not very well recognizable on polarized dermoscopy. But if we use the UV dermoscopy, we can see that this serpiginous white tract, light blue tract, is much more evident. So this is of course scabies. Another case, of course, in this case we can see the brown triangle, the burrows, but if we use the UV dermoscopy, we can also appreciate the eggs of the mite. What about foot intertrigo? Intertrigo is very difficult to be differentiated on from an etiological point of view, from a clinical but also a dermoscopic examination. But if you use the UV dermoscopy, you can see green in this case, red in this case on the bottom, and in the middle we don't see any fluorescence. So basically we can recognize that the one on the top is Pseudomonas photointertrigo, the one on the bottom is Erythrasma, and in the middle is Tinea pedis. We don't see fluorescence in Tinea pedis because in most of cases Tinea pedis is due to trichophyton, which does not show any fluorescence. You can see pitted keratolysis and still the red fluorescence. And here another differential diagnosis, pityriasis versicolor versus macular progressive hypomelanosis. They are very similar from a clinical point of view, as you can see, but on dermoscopy they are different. In macular progressive hypopigmentation, we have this central follicular red fluorescence, which is due to the presence of Cutibacterium macnes producing porphyrins. In achromic pityriasis versicolor, we have two patterns, the so-called blackout follicular areas. These areas are characterized by the interruption of the homogeneous follicular red fluorescence, which is typical of the normal back of every patient because we have Cutibacterium macnes, so we have a lot of follicular red fluorescence. When we have Malassezia, we have some areas devoid of this fluorescence, so we call them blackout follicular areas. On the other hand, we can also have green fluorescence, which is also visible on the food light. So let's come back to our patients. Here we don't see red fluorescence, so this is of course achromic pityriasis versicolor. On the other hand, here we have in the center of each macule a tiny red pinkish fluorescence. So this is macular progressive hypopigmentation. Here another differential diagnosis, Malassezia follicularis and acne, and still it's not too easy to make the differential diagnosis between these two conditions on clinical ground. If we use polarized dermoscopy, we don't see any relevant clue, but on UV dermoscopy we can see some points of differentiation. In Malassezia follicularis, we have a blue follicular fluorescence. In acne, we have still the blackout follicular areas where we have inflammatory lesions because in acne, we have a lot of Cutibacterium macnes responsible for the presence of follicular red fluorescence, but in the areas in which we have inflammatory lesions, we have hypoxia, and so the density of Cutibacterium macnes is reduced, so porphyrins are less concentrated, and we see this blackout follicular areas. So these areas devoid of follicular red fluorescence. So let's come back to our patients. Let's see this case. We have blue follicular fluorescence. So this is obviously Malassezia folliculitis. In this case, we have blackout areas in the areas in which we have inflammatory lesions. So this is acne. So you can see how UV dermoscopy may be very helpful in facilitating the recognition of many infectious diseases, and this is a novelty in the field of dermoscopy, especially infectioscopy. These are two papers dealing with UV dermoscopy, which are free on PubMed, so you can read them. If you need anything, you can write me. And I find UV dermoscopy very helpful, but if you don't find UV dermoscopy very helpful, you can also use the UV light to write some cryptic messages, as in this case this is my Italian team favorite team. Thank you very much. I'm available for any requests. This is my email address. Bye bye and enjoy the rest of Congress.
Good morning to everyone. Thank you for the invitation also this year. And we have this first talk about dermoscopy of common hair disorder. I'm Michela Starace from University of Bologna. We can divide our talk on the basis of three different aspects of the hair shedding. So we can have hair disorders on the basis of a diffuse hair loss, on patchy hair loss, and patterned hair loss, and how it is so helpful trichoscopy to look at it to do diagnosis. So we started with the first one, so update and trichoscopy on diffuse hair loss. When you have a diffuse hair loss, it's always too important to do this central line to understand if it is or not a hair thinning. So when you have this situation, my first point, my first thought is this always an androgenetic alopecia? So with the clinical, not always it's possible to do it to have this affected disease. But if you put your dermoscopy, you can see 4 different cases and 4 different diagnoses with trichoscopy. It's easy to recognize or to suspect. As you can see, of cases of androgenetic alopecia, telogen effluvium, alopecia areata incognita, and diffuse lichen planopilaris. So trichoscopy of diffuse hair loss, it's important to approach in a different way. It's important to compare, first of all, the anterior region versus the occipital area to confirm or not the presence of typical sign of androgenetic alopecia. On the other side, don't forget to look at the temporal region, especially to look at the sign of telogen effluvium and the parietal zone. Upper side, it's better to recognize alopecia areata incognita and down parts for the lichen planopilaris. Do it absolutely on the diagnosis, but you can also follow the patient in a very certain way. So don't forget it because it's possible to show you, but to show to the patient the effect of the therapy. Here are the first cases where we can see, first of all, diameter variability. So it's very important when it is higher than 20% of the cases. The presence of empty follicle, and the other side, the last one, it is the peripillar hair. This is the diagnosis of androgenetic alopecia. Androgenetic alopecia is a progressive, non-scarring miniaturization of the hair follicle in the typical area of the anterior with the comparison of the occipital area. Can affect both female and male patients. Diagnosis today is by trichoscopy. Don't forget that the progression is very slow by time, but when there is the diagnosis of this disease, you have to start immediately a therapy. The trichoscopy sign is well recognized while described on the pollen group with this important sign: reduced of the hair thickness, reduced number of hair, and peripillar hair. It's possible to have a diffuse form of androgenetic alopecia, difficult to recognize, but we have to suspect it when all the miniaturization is all over the scalp. You have to diagnose it with biopsy in these cases, and it's important to start with a high therapy, as in this case in my patient with topical minoxidil and oral dutasteride. And you can see with also with trichoscopy a great improvement of this patient. In case we have absence of diameter variability, as you can see, then we have this short regrowing hair, we can have a case of telogen effluvium. In the telogen effluvium, our approach is especially to understand if there is a trigger event 2-3 months before the starting of the shedding, without anything but only hair loss diffusely, and it is a good prognosis, especially if you can look at where it is the specific trigger event. With trichoscopy, we can analyze, first of all, the absence of diameter variability, compare again anterior area versus the occipital area. Look at the temporal area where there is the temporal thinning, typical of the telogen effluvium, both acute and chronic, but very important in acute form, the presence of this short regrowing hair diffusely on the scalp. On the trichoscopy, this is the last paper that is published that there is not a specific sign because telogen effluvium in many cases is together with other disease can induce telogen effluvium, seborrheic dermatitis, and so on. In this case, we have first of all pigtail hair, very much hair, and yellow dot. This is a case of alopecia areata incognita. Alopecia areata incognita affects especially the female patients, young female patients, many times together with alopecia, androgenetic alopecia associated. It's an acute onset, less than 6 months, with a diffuse thinning and diffuse shedding. On trichoscopy, we were to analyze typical signs that we described many years ago as yellow dot, empty follicle, short vellus hair, and pigtail hair. Is diagnostic. If you have any doubt, do a biopsy. In case of perifollicular hyperkeratosis, erythema, skin atrophy, think about lichen planopilaris, again in diffuse form. And you can see it is a variant of the typical lichen planus. You can see a variant of it, and you can see this redness diffusely, but you have to do biopsy to confirm this diagnosis. The trichoscopy sign of LPP is the absence of follicular ostia, the skin atrophy, the skin areas, and a hyperkeratosis and hair cast that you can visible by dry trichoscopy and do erythema. So in case of diffuse hair loss, these are the most important common causes. Trichoscopy can be very useful to do the diagnosis of this disease. Sometimes they can require a biopsy. We move versus the trichoscopy on patchy alopecia. And when we have a patchy alopecia, my point is, it is always alopecia areata? No. You can see on the clinical some suspected, but trichoscopy helps you to distinguish the four typical cases. In trichoscopy of patch alopecia, you have always to do the trichoscopy inside the patch, at the periphery, and in healthy area at the time of diagnosis, but also during the follow-up. In case of the presence of black dots, exclamation point mark hair, dystrophic hair, no doubt about the diagnosis of alopecia areata. Alopecia areata sign are well described in a lot of papers. Not here the type that we can describe. The typical sign are yellow dots, black dots, exclamation point mark the hair, pigtail hair also in group or in regrowing as a circular hair. So it's very important, and with the trichoscopy you can understand it is a chronic phase, is an acute phase, or it is a regrowing phase. But to use also trichoscopy to understand which is the result of it. So evaluate the response to the therapy. Acute, as you can see, started topical steroid, but if you can see some sign, don't forget to stop it, but continue it until there is the absence of any sign of the acute form. This is an update, but at the end, all these paper confirm the role of trichoscopy to look at it with yellow dots, black dots, circular, and exclamation point mark here. If you have black dots, dystrophic hair, hair-powered, inflamed hair, you have a case of trichotillomania. In trichotillomania, dermoscopy is very useful to do diagnosis, absolutely, but don't forget to use it in a specific, special site. As you can see, eyelashes and hair brown, where it is very difficult, especially we don't have any sign on diffusely. In Abraham's, there is a paper that describes the typical sign on the scalp. To look at it also in hair brown, as you can see, all the sign, broken hair, colored hair, hooked hair, and also in eyelashes, where we have especially irregular broken hair, black dots, and flame hair, even if the scalp is completely normal. Another important is on the bird. You can see the typical sign is round hemorrhages around the stems. This is a chaotic appearance. It's very easy because it's not easy to pull out a bird. And finally, it's possible to have trichotilla incognita. Don't forget. Is not clinically evident, but all the sign of trichotillomania is well present, not in a patchy area, but diffusely. And we can see the typical sign. In this case, we have comma hairs, Morse code hair, and hair cast, and also zigzag hair. This is a sign of tinea capitis. Trichoscopy sign again is well recommended to look at it to do diagnosis of with the trichoscopy to start the therapy. It's better also to have a culture examination to confirm the species specific. Usually we have this typical sign in microsporum affection. On the other side, in case of trichophytum and especially black race, we have the cross-Q hair that is the typical hair due to the spiraliform form of the hair of this type of population that confirm the diagnosis. But it's important to use trichoscopy to look at the result before the result of the culture examination. You can see this patient after the treatment, and you can see even if there is some patchy area, but on trichoscopy without the absence. Then the trichoscopy with the complete resolution of the situation. If you have on the other side black dot, dystrophic hair, yellow dot, but cicatricial alopecia, think about a pressure alopecia. In pressure alopecia, you have to suspect it when there is a history of prolonged surgical intervention, prolonged pressure on the scalp, especially. It's possible to have the presence, but also the absence. It depends on which time you arrive to do diagnosis. And on the other side, the possible crust, serrematic crust. So in case of a patchy alopecia, these are the common causes. Clinical is very suspected. Microscopy is useful. Rarely we can require a biopsy, but the medical history can help you so much. But don't forget it's possible to have patchy alopecia in cicatricial form. And my suspect is always it's a lichen planopilaris. Why? Because it's only the most frequent. And with the trichoscopy, you can show that it's not a LPP, but it is 4 different diagnoses that can affect the same area of the vertex region. So in case of perifollicular hyperkeratosis, red area, pili torti, and white area, this is the typical LPP. Trichoscopy sign of LPP is well described in a lot of papers, in a lot of publications in this heart. The last update is about only the correlation of this LPP with the histopathological aspect to understand if it is possible only with trichoscopy to do diagnosis without the avoiding of biopsy. In case of perifollicular hyperkeratosis, tufted hair, pastels, and dilated vessel, this is the folliculitis decalvans. Today, trichoscopy is absolutely diagnostic to look at the sign of diagnosis of tufted hair and absence of follicular osteum, and also the other sign to look at the activity. And for this reason, it is better to use a dry dermoscopy to look at the scales and the crust with water to better visualize the vessels. And the last update, again on trichoscopy, is about especially the correlation with the histopathological finding, to use again to confirm again the sign of trichoscopy that confirms the diagnosis without the use of biopsy. In case of red dots, keratotic plaque, dilated vessels, and cicatricial area, this is the lupus erythematosus discoide. The trichoscopy sign is well recognized with absence of follicular ostia, red dots, the keratotic plug, dilated vessel with the tortuous aspect, and blue-gray dots. Also, all the update again confirm the role of trichoscopy, trying to avoid the use of invasive way as a biopsy. In case of anagen bulb visible through the skin, serum crust, perifollicular hyperkeratosis, scarring alopecia, you have to think about erosive pustular dermatosis of the scalp. These are all the most important trichoscopy signs of this disease that confirm the role of trichoscopy, but it is better to use the biopsy to confirm. Don't forget to ask the medical history. This disease on the scalp arrives always after a trauma, locally trauma on the scalp of the patients. And finally, we have the patterned hair disease. And when we have especially the involvement of the attachment of the scalp, we have to think always FFA. But we have a lot of other disease that can induce with the aspect of this part. And on trichoscopy, you can have some idea. You can see 4 different trichoscopy of the hairline and 4 distal disease. There is a form of alopecia areata characterized by vellus hair, yellow dots, and broken hair that can suspect, in this case, an alopecia areata. The most important that is the absence of an exclamation mark here. For this reason, it's very difficult to do diagnosis, and it is better to do biopsy because they can have this atrophic aspect of the patch area. And another can be the typical sign of broken hair, white area, and empty follicle. In this case, we can suspect atraction alopecia. It's very rare to have in the Caucasian patient. It is very frequent in American African population, and the typical sign are red cast, white patches, and white dot. It's induced by the cosmetic procedure of this type of patients. It's important to stop it to avoid any cicatricial, unfortunately, consequence of this type of typical eye styling. In case of perifollicular hyperkeratosis, absence of vellus hair, intermediate hair, residual empty follicle, and the presence of pili torti, we have absolutely to think of a cicatricial form of the attachment as frontal fibrosing alopecia. The sign, the trichoscopy sign of FFA are very similar to LPP, as you can see, and we can look at it with a typical update on the clinical dermoscopy aspect about this multi-center study of International Dermoscopy Society. The great news are about the sideboards, that where is the trichoscopy can help us to look at it. This is the FFA, even it is only concentrated on this part of the scalp, peripillar cast, peripillar erythema, pili torted, broken hair. And on the, again, especially on the A brown, where you can see the typical sign that can help you to distinguish it versus the alopecia areata, and also look at the aspect of this hair or the hair brown, because it's possible with the homogeneous aspect to do therapy, because it's possible to stop it. In case of confusion aspect, it is absolutely unuseful to do therapy because it is a cicatricial form. So in this case, we have a good prognosis sign, and in other case, scaring aspect already. The trichoscopy aspect is about especially eyelashes, that we can see especially the two important points. On the upper eyelashes, the visualization of the hair bulb, and on the focal atrachea of the lower eyelashes. So finally, on the patterned hair loss, these are the most important situation. It's a clinical, they are very difficult to diagnose. The trichoscopy can be useful to suspect, but often this type requires biopsy to be sure. I would like to thank you for the invitation and for the attention. This is a kind invitation of this complete on-demand course. If you have, if you want to look at the better, you want to study onychoscopy and trichoscopy on demand. Thank you.
Dear colleagues, my name is Paweł Pitkiewicz, and I have the honor to represent Polish Dermatoscopy Group. Today, I have the pleasure to speak on our recent research paper investigating endocrine clues in melanoma. As you may remember, hyperpigmented perifollicular circles are one of the dermatoscopic clues to lentiginous melanomas on sun-damaged facial skin. Presence of these structures is suggestive of lentiginous spread of malignant melanocytes down the hair sheath, below the level of dermal-epidermal junction. If the infiltration is shallow, we can see a brown circle, whereas if it extends deeper down in the dermis, we can see gray, even though malignant melanocytes remain in the hair sheath epithelium, so remain in the inside to phase. In acrolentiginous melanomas, gray microcircles located atop the ridges are the clue to the presence of melanoma nests extending along the eccrine ducts from the crista profunda in the media. Knowing that gray color develops when melanin is below the level of dermal-epidermal junction and how pigmented circles develop, meaning either due to regression or malignant melanocyte migration down the adnexal epithelium, we hypothesized that similar phenomenon may occur in non-acral and non-facial skin. Thus, we decided to look for the periadnexal hyperpigmented microcircles in extrafacial non-acral melanomas. In our pilot study, we wanted to check how frequent are hyperpigmented microcircles in melanomas and in the imitators. How are they distributed if they are present? Whether they are linked to regression structures, whether they are more common at sites with higher cumulative sun damage, and what is their diagnostic accuracy. We have included pathology-confirmed dermatoscopic images from ISIC database with metadata, including sex, age, and non-acral, non-facial site into our study group. We excluded duplicated cases, photographs with image quality issues, incorrectly labeled concerning site, nodules, and achromic lesions that gave us about 5,400 cases for a blinded writer. Here are two demonstrative cases with central and peripheral distribution of microcircles. These are really small structures, and I can admit that the image quality was suboptimal, so it required some effort to realize they are not clots, but are round and characterized by darker periphery and lighter center. Here you can appreciate such an green hyperpigmented microcircle under optical super high magnification dermatoscopy. It's marked with the black arrowhead. Hyperpigmented microcircles were significantly more common in melanomas than in nevi and other melanoma simulants, but over 90% of them had peripheral distribution. We did not observe this significant correlation with central hyperpigmented microcircles, so in post-hoc analysis, we focused just on the peripheral ones. Peripheral hyperpigmented microcircles proved to be a very strong clue to melanoma, with a fragility index over 500 versus nevi and over 1,100 versus others. This was true regardless of regression status, proving that the clue is not entirely dependent on regression. This clue was especially valuable in hypopigmented lesions, which is important as these tumors are usually diagnosed later, at more advanced stage, and thus have poorer prognosis. As hyperpigmented circles develop with lentiginous growth, we expected that melanomas developing on sun-exposed sites will feature peripheral hyperpigmented microcircles more often, and that proved true in post-hoc analysis. Apart from central and peripheral distribution, later on we've noticed that these structures can present in relation to surrounding structures. And first relation is free hyperpigmented microcircle, not connected to any structure. Secondly, hyperpigmented microcircles can be located along the angulated lines, sometimes interconnecting them. And finally, hyperpigmented microcircles can be present at the periphery of hyperpigmented follicular circles, being responsible for the signet ring appearance. We speculated that a green duct ostia could give rise to dotted microcircles or microisobal sign, and we found this in some of the photos. Follicular dotted circles are labeled with black arrows, whereas green dotted microcircles are labeled with white ones. We suspect that these may develop with melanocytes infiltrating the duct and migrating upwards. We have asked 7 raters to label the cases with hyperpigmented microcircles to assess the inter-observer concordance. Price kappa was fair for all raters and moderate for expert only, whereas interclass correlation coefficient was fair for single rater and good for average, and moderate for single expert rater and good for average. Of course, we intended to correlate peripheral hyperpigmented microcircles and melanoma subtype, yet we faced an unexpected problem. Unfortunately, we were unable to perform such testing as in the entire ISIC database with almost 70,000 cases, there were only 39 subtypified melanomas, and majority of them were superficial spreading melanomas, and there were 2 nodal ones. That was an exclusion criterion. So we hope to do it with our own dataset in a secondary study. For now, our impression is that these are more common in lentiginous melanomas. We also checked whether the peripheral hyperpigmented microcircles can be used as a discrimination measure for melanoma with a predictive model. In all the models we tested, peripheral hyperpigmented microcircle coefficients proved to be significant determinants of melanoma. We also observed that adding hypopigmentation gave additional uplift to the power of prediction. And interestingly, peripheral hyperpigmented microcircles were stronger indicators for melanoma than regression, but area under the curve further increased when both features were included. Summing it all up, we would like to introduce peripheral hyperpigmented microcircle as a useful dermatoscopic clue to non-acral, non-facial melanoma, especially the ones developing on sun-damaged skin. We have proved its predictive power with general linear logistic model, regardless of regression or hyperpigmentation status. Of note, this was not true for central hyperpigmented microcircles. Inter-observer concordance was moderate, which was likely due to the small size of the structure and sometimes suboptimal resolution of the images from the ISIC database. I'd like to thank all project collaborators who took part in the Inter-Observer Concordance assessment. Should you like to read our paper, here is the QR code to the article. Alternatively, I'll be happy to share it with you upon request on my email. Thank you very much for your attention.
Hello everyone, my name is Verica Todorovska. I'm from Macedonia. I'm very happy to be with you on this 2025 World Skin Health Day. My topic is about scalp tumors. We refer to the scalp as a special site. And what is special about this site? The skin differs from skin of other anatomical sites. It is thinner, with flat red ridges and high densities of follicular openings, sweat and sebaceous glands. This makes the clinical and dermoscopic assessment of the lesions more difficult and challenging even for more experienced dermatologists. And this area is frequently neglected during dermoscopy screening and self-examination. What can we expect to find on this location? The majority of scalp tumors are benign, 93 to 99%. Half of them are cysts, 30% lipomas, and 28% melanocytic nevi. Seborrheic and actinic keratosis are increasingly common with age and hair thinning. And here are some examples of the most common benign tumors, starting with cysts, pilar or trihilemal cyst and epidermoid cyst, with typical central opening. Seborrheic keratosis on the scalp can pose a real diagnostic challenge with melanoma as the main differential. One color, overall symmetry, and keratin elements are in favor of seborrheic keratosis. Actinic keratosis are the regular findings on the bald scalp of an elderly males with substantial UV damaged skin. You can see beautiful rosettes and some pigmented scales in between the open white and white follicles. Cocate or eclipse nevus is a special type of nevus typical for the scalp, showing peripheral hyperpigmentation encircling the central hypopigmented area. This is a dermal papillomatous nevus, a common finding on the scalp. Blue nevi are very frequent, especially the ones with late onset. This is the only nevus that can appear at any age. It can be flat or slightly raised. With still blue homogeneous pattern, the main differential here is melanoma metastasis. So ask for any history of melanoma, previous nevi excisions, and look for additional similar lesions. Nevus sebaceous, an organoid nevus with 0.3% frequency, a congenital hamartoma with a potential of 10 to 30% to develop into a secondary benign or malignant tumors. Recent studies have revealed that development of malignant tumor, including basal cell carcinoma in nevus sebaceous, is very rare, 0 to 3.5% only. In fact, most of the previously reported BCC are now believed to be trichoblastomas. Along with syringocystadenoma papilliferum, they are the most common benign tumors associated with nevus sebaceous. Now, most authors do not see the need for an indication to remove a sebaceous nevus in childhood as prophylactic measure. Trichoblastoma usually develops as a pigmented or non-pigmented nodule, with dermoscopy features suggestive for BCC, translucent background and ramified vessels on the left, even white shiny lines, or large blue-gray clot in pigmented variants on the right. This is the best BCC mimicker. Vascular tumors like angioma can be found in this area too, showing typical red clots and white intersection lines. Adnexal tumors are sporadic findings like cylindroma, spiradenoma, or even eccrine poroma, this is pigmented variant. Around 2% of cutaneous malignancies arise on the scalp. They can be primary tumors or metastases. The most common malignant scalp tumors include basal cell carcinoma up to 41%, squamous cell carcinoma 70%, followed by more rare cutaneous metastases, melanomas, adnexal tumors, angiosarcomas, and lymphomas. The most common BCC. This is the superficial pigmented type, which can be often seen at the hairline in younger adults. This patient was only 27 years old and treated seborrheic dermatitis at first. After dermoscopy diagnosis of superficial BCC and refusal of surgery, cryotherapy was done. The patient returned 2 years after with a large infiltrative ill-defined subsurface lesion. The margins were identified with use of UV dermoscopy. So my message to you is to never spray a BCC on the head. We can see BCC also on the vertex with thinning hairs, superficial pigmented, or a nodular variant. This nodular BCC developed under a hairy scalp. On close examination and with use of UV dermoscopy, true margins were identified. It was a mixed type of BCC with nodular and superficial part. You can see how large is in fact the lesion. This case was very interesting because the plastic surgeon suspected a melanoma and wanted to make a large excision. On dermoscopy, multiple features in favor of BCC. Blue and white instead of blue and black color, like in melanoma, linear instead of polymorphous vessels, and shiny white areas instead of lines. The blue color originates from the hemorrhage of the necrotic tissue in the cystic compartments of this rare form of cystic BCC, which looks like the Earth from photograph from the space. ACC or squamous cell carcinomas are also common on the scalp, especially in bald elderly men on the background of an extensive UV damaged skin, which is the main etiologic factor for developing of this type of ACC. This is a keratoacanthoma like squamous cell carcinoma with white circles, central keratin plaque, hemorrhagic spots, and linear looped vessels at the base. Here are the same findings, and in this grade 2 medium differentiated squamous cell carcinoma with large central ulceration. Scalp melanoma represents 35% of cases of head and neck melanomas and is accountable for 7% of all melanomas. They carry high mortality rates, with a 10-year survival rate of only 60%, which lead them to be named as the invisible killer. Worse prognosis compared with melanomas on other body sites, likely because of late diagnosis due to hair coverage, difficulties in interpreting dermoscopy findings, and its unique molecular profile. Biologically more aggressive compared to melanomas on other locations. There is increased depth of invasion even in lower Breslow. And do you know that up to 25% of scalp melanomas are developing in a hairy scalp, not on a bald scalp, which means usually late diagnosis and grim prognosis, unfortunately. They can present as any type of melanoma, starting with this superficial spreading melanoma type. Usually they are found in younger patients. This was only 27 years old with a family atypical mole and melanoma syndrome. Superficial spreading melanoma on the scalp are mainly and more frequently characterized by regression features, as in this example, atypical pigmented network, blue-white structures, irregular pigmented clots, and atypical vascular pattern. Here are two more cases of superficial spreading melanoma type in young males. This is only 36 years old, and unfortunately melanoma was already invasive. And the second is 44 years old, and fortunately here the melanoma was still in situ. You can see there is only black and a brown color and a lot of regression. Lentigo maligna type can be usually seen on the vertex region in a bald man. Dermoscopic features are typical for lentigo maligna with annular granular pattern, gray color, and rhomboidal structures. This patient developed amelanotic nodular melanoma on the scalp covered with hair. 62 years old. This fast-growing tumor with yellowish background, small caliber linear irregular vessels, and thick epidermal colorate due to the fast growth. This is another hypomelanotic nodular melanoma, where large caliber ramified vessels and a mass of keratin with mixed of serohemorrhagic rusts were in fact misleading to a basal cell carcinoma. So always put nodular melanoma in the differentials when evaluating suspicious nodular lesions. Merkel cell carcinoma and angiosarcoma are the most aggressive malignant tumors found on the scalp in elderly male and have the worst survival rates, 10 to 20%. Clinically, MCC presents as a rapidly growing red nodule, showing unspecific dermoscopy pattern with polymorphous vessels and milky red background, while angiosarcomas can often mimic benign painless skin lesions as hematomas or simple hemangiomas. They usually present with these polychromatic dermoscopic structures on a homogeneous purple or dark red color. The scalp region accounts for 6.9 to 13% of all cutaneous metastases, usually appearing in late stages of internal malignancies, but sometimes as the first sign, helping us discover the primary tumor. Most frequent tumors that metastasize on the scalp are lungs, gastrointestinal, prostate, and breast cancer. This is an example of a cutaneous metastasis of sigmoid adenocarcinoma. And here we have so-called alopecia neoplastica, a breast cancer scalp metastasis showing a milky red area, yellow dots, and orange amorphous areas. This can be easily taken as one of other forms of alopecia if there were not for the polymorphous vessels. In conclusion, the scalp is a frequently neglected region during dermatological examination and also difficult for patients to self-examine. We must incorporate scalp inspection as an essential part of the general screening for either skin or internal cancers. And for the end, we all know that hairdressers, in fact, have better visual access with the scalp on a regular basis. And most of adult people see their hairdressers far more frequent than their doctors. So education of these non-medical professionals could be of great importance for prompt cancer detection. Thank you all for your attention.
Hello everyone, welcome to the webcast of the Guinea World Skin Health Day Congress. I am Anna Słomiak-Wąsik from Poznań, Poland, and I am honored to present some information about dermoscopy in common hyperpigmented dermatosis. At first, I'd like to mention that the presentation contains only my own pictures, mostly of pale skin types. Some pictures come from my first attempts at UV dermoscopy, so they are not perfect, because UV fluorescence dermoscopy requires special conditions, such as dark room without light reflections. I used the Dermlight Del5 dermoscope device with UV light at 665 nanometers. We are going to discuss only a few prominent hyperpigmented dermatoses localized on both the face and body. So let's start with the body. The first and very common disorder I'd like to discuss is notalgia paresthetica and friction or rubbing melanosis. It's a localized pigmentary disorder caused by repeated friction, especially in the upper back region. It often results from mechanical stimulation by body brushing utensils. And in notalgia paresthetica, primary itching or other skin sensations lead to localized and repetitive scratching. Dermoscopy reveals brownish patches that might be structureless or form a network-like pattern. Sometimes white scaling can be observed due to hyperkeratosis and skin dryness. Both darker blotches and scaling are enhanced by UV dermoscopy, clearly showing the reticular pattern. The next interesting entity is ashidermatosis. This disorder mainly affects young adults on the trunk, and it is considered idiopathic. The clinical presentation consists of asymptomatic gray-bluish macules. Dermoscopy shows gray-bluish dots, known as peppering, on a hypo or hyperpigmented or bluish background. UV light further emphasizes this pattern. Terra firmiforme dermatosis, it's next and a beautiful example of the usefulness of UV light dermoscopy, which we had the pleasure of presenting in our paper mentioned on the slide. Terra firmiforme dermatosis resembles dirty skin, but the lesions occur despite proper hygiene. Thus, it is considered as a keratinization disorder. Dermoscopy reveals brownish plaques represented by pale blue plaques in UV fluorescence dermoscopy. One striking feature is that a simple test with a 70% alcohol rub results in the disappearance of the plaques, which is clearly visible under UV light. It should be, of course, distinguished from dermatosis neglecta, where the accumulation of dirt is clearly visible in the skin markings. Dermatosis neglecta may also appear as irregularly distributed cornflake-like dark brown scales. And now let's move to the face. The most common hyperpigmented findings on the face are solar lentigo, pigmented actinic keratosis, and flat seborrheic keratosis. Although this is not the time for an in-depth evaluation of these conditions, it's worth mentioning the crucial role of an inverse approach in dermoscopic diagnostics. This helps rule out lentigo maligna before laser treatment, which leads to better outcomes. UV light may also be applied in the diagnostic and therapeutic process of melasma and acquired multifactorial chronic pigmentary disorder with a strong genetic predisposition. These usually bilateral pigmented macules and patches may present in two forms and often both simultaneously. It's an epidermal variant with a darker appearance and well-defined margins, and a dermal variant with a brown-grayish hue and ill-defined borders. Dermoscopy reveals a pigmentary pseudonetwork with a grayish hue and deeper dermal lesions. And these subtle differences are enhanced by UV fluorescence dermoscopy, where epidermal pigmentation appears darker while the contrast in dermal pigmentation decreases. This phenomenon, previously observed with Wood's lamp examination, can help predict treatment outcomes, as deeper lesions are much harder to treat. Now, I'd like to show you some peculiar images of exogenous ochronosis, a pigmentary dermatosis resulting from the use of certain drugs and substances, such as antimalarials, as in this case, and hydroquinone. It typically presents with a darker bluish hue and affects the malar areas, temples, and cheeks. Dermoscopy reveals a variable morphology, including globular, dotted, annular, and even curvilinear structures with visible follicular openings. It is often accompanied by diffuse depigmentation. The appearance under UV fluorescence dermoscopy depends on the pigment depth and hyperkeratosis, which may result in a bumpy surface. Exogenous ochronosis may sometimes be mistaken for Real melanosis, a form of contact dermatitis caused mainly by allergens in cosmetics, and here the culprit was a hair styling product which is still in use as seen. The clinical presentation varies according to the causal agent, ranging from light brown to grayish and bluish discoloration. Typically, it affects the forehead, zygomatic, and temporal regions. Dermoscopy shows a pigmentary pseudonetwork, gray dots, globules, and patches, result of pigment incontinence. Other findings include a perifollicular whitish halo and follicular hyperkeratosis, which are beautifully enhanced by UV fluorescence dermoscopy. I'd like to conclude with a beautiful image of common freckles under UV fluorescence dermoscopy. And I also want to highlight that this marvelous position in the publishing markers have this as the foundation for the small lecture, enriched with novel UV fluorescence techniques. Thank you for your time and attention, and I am really honored to have been invited to speak today. Thank you and goodbye.